welcome.
Thank you so much for the invitation. So what a wonderful opportunity to connect with the community organizer and to, because in a nutshell, what I think of community-based participatory research, it's organizing with data. So it's kind of the link between the organizing world and the academic world that I struggle with all the time. I've been in New Mexico 35 years. A lot of my work has been with tribal communities, a great honor to have the generosity of the communities in working with me. For all these many years. I've done a lot of work in Latin America in participatory evaluation with healthy municipalities, also in rural New Mexico. But I wanted to kind of today, as much as possible, and also just love that we go back to our roots. You know, I also very much started in organizing in the 60s and with the farm workers and women's movement and anti-war movement. So organizing has been key to who I am as an academic. And I came into the University of New Mexico in the mid-'80s as faculty and have been there since trying to create this bridge. And I think there's a lot of bridging that is possible through this committee. I'm greatly relieved that there's a committee finally around creating solutions and not just characterizing the challenges that we all face in terms of inequities. So I thought I'd give a little bit of background to just CBPR. Some of you are deeply steeped in it, some of you it may be new to. Then present just through a number of case studies how to think about the use of logic models, how to think about what is evidence, how to think about I mean, there's a great paradox that exists in the world of, I'm an interventionist, I'm an intervention scientist. There's a great paradox in the world of intervention science that the more narrow and targeted your intervention is, the more likely you're going to have very specific health outcomes. The more you build capacity, the more you are building for a range of system and policy change with broad coalitions, the distance is longer for multi-system change. But it's, I think, as greatly shown by Doran this morning, critically important for local democratic change in health equity and regional democratic change in health equity up to the state level, maybe even nationally. But I want to end with the study of what is CBPR? You have my model there in front of you. I'm going to talk you through it. And what are we trying to measure when we're measuring health outcomes? And I do want to say that, yes, you asked, Jim, I am a recipient of, I am currently on 2 R01s, the PI of 2 R01s. 2 of them are represented here. I have a couple case studies, so that's my disclosure. That one is from the National Institute of Drug Abuse and one is from the National Institute of Nursing Research. But I didn't, okay, so I didn't put that in my slides, but thank you for that. I have starting points as well, and I think one of my most important one of the canons of good research is that it should never hurt the people studies. There are decades, there are centuries of years of research abuse in communities, not just historic, current. There's a current issue with Acoma Pueblo right now where someone came in and wrote a book and revealed ceremonial issues that should never have been revealed outside the community. And so it is not just a historic challenge, it's a constant, continual challenge how to think of research. And I go back to one of my distant mentors, Paulo Freire. He wasn't a researcher, so I just substitute the word research. But to be a good educator means above all to have faith in people, and here we have a resurgence of issues of faith again, and believe in the possibility that they can create and change things, which is the bubble on the right there that Doran showed. So thank you for that. So as a scientist, I think that we face several challenges as interventionists. The first is just bringing evidence to practice. There was that issue that arose where people talked about the 17-year lag between lab findings into being committed then into practice. However, it isn't just lab findings. It's any evidence that may be found to be effective in one particular context, that internal validity is insufficient in terms of knowing whether that same intervention could be effective. So what might happen in Chicago or inner city Chicago or New York or Minnesota, coming down to the pueblos in New Mexico, may be a wonderful violence prevention curriculum up there, but what does it mean to contextualize an intervention, to change the intervention so that the evidence that may be useful, the kernels of evidence that may be useful, can still be applied in a very, very different context. So external validity as a scientific challenge is critical. I want to ask us too, I live in the medical world. I'm at the School of Medicine. We're always talking about evidence-based practice, evidence-based medicine, evidence-based public health. I'm a public health person. But what truly does that mean? That's really what has actually been had sufficient dollars to have the randomized controlled trial to be published to enter the academic literature. There's a lot of practice out there. My colleague Larry Green has talked a lot about practice-based evidence, and of course that exists in the clinical world quite a lot. But in community worlds, in community cultural worlds, in indigenous knowledge, there's a lot of evidence of healing. There's a lot of evidence of practices that may not be and may never should be systematically studied. But we talk about this in sort of the world of hybrid knowledge. How do you create a world of hybrid knowledge where the evidence can be expanded and multi-level and multi-based from different perspectives? That's a really key value base that I think intervention world is moving towards as they talk about complexity science and the world understanding contextual, the seriousness of understanding context. So I think the evidence is also within those multiple contexts. We always, you know, the big world now in NIH is translational medicine, translational science. How do you bring findings into practice? But there's a challenge. It's generally perceived as a one-way translation. We'll learn what we need to know in the university. We'll translate down to the community. And so we're always trying to insert the language. Well, what's bidirectional really mean? And that's the same kind of issue as that multiple evidence is. I mentioned this world, the challenge of research mistrust, and of course the challenge of use of findings, even with people who do CBPR, who are working with communities in terms of having those findings used for programs, practices, actions, and policies. So just as a definition that I find the most useful from the Kellogg Foundation, CBPR collaborative partnership equitably involves all partners, starts with a process that is, you may see this often, with the research topic of importance to the community, and the aim is knowledge for social change and action again, not just knowledge to be published. As Dennis Raphael, from Canadian colleague, has often said, if it's something gets published in social science and medicine and nobody reads it, does it exist? So, you know, so what we do as academics needs to actually have impact, as you are sitting here all know. In New Mexico, we have a New Mexico Health Disparities Center. We kind of found this very helpful to create. There's much research that happens on communities. You identify your census tracts or your demographic clinical populations. You just do your research around that identified community. Much research happens in community settings, in homeless shelters, in churches, in schools. What happens when you consider research that is with community partners? How does research change? And how does the possibility of having a broad range of outcomes then change? And it's a shift. It's a huge paradigm shift. Not all research maybe is a with model, but there's a lot of research that should be a with model. So just a set of principles. These are Barbara Israel and colleagues' principles from decades, recognizing community as a unit of identity, recognizing strengths, recognizing long-term commitment and capacity, balancing research and action. In my personal world, having done community-based participatory research with tribal communities for decades, I have to enter another world of recognizing that there's tribal sovereignty, that tribal systems need to be honored. I cannot do research unless there's tribal council resolutions, governor's letters, go through Navajo Nation IRB, Southwest Tribal IRB, and the critical knowledge that the data belongs to the tribe. It's very different to have that knowledge, and not all communities have those governance structures, of course, but ethically the question is the same. Who does the data belong to? How do you collaborate, at least at a minimum, to share the ownership of the data? And of course, for me, I can't publish anything without many, many approval processes and co-authorship, which of course is extensive in time commitment. So it's a challenge for junior faculty coming up through the pipeline. There's all these challenges of even just doing CBPR. So I'm just going to carry the story through on multiple examples. This is part of our work with a couple different tribal communities, and as you see, a 15-year relationship. I don't know if there's a, is there a, okay. So we started with the CDC Social Protective Factors Grant with one of the Pueblos, where we did ethnographic interviews with them. What were the capacities of the tribe? We started with another 2 tribes doing an analysis of what they wanted to study in their own community. They said they were tired of being researched to death. They wanted one single profile that could work with health, housing, law enforcement, Head Start, water, land. And together, they actually created a way to measure or to think about how to look at cultural transmission of language and issues of fears of loss of language, historical traumas historically that they've been subjected to. And at this point, we had these 2 grants in different ways working with different communities. I would say at this point is where our CBPR process started. All 3 of these communities came to us and said, can you help us identify an intervention that would strengthen our family communication and strengthen the transmission of culture and language? We got permission to come in with our appropriate tribal council resolutions, but the ideas hadn't really come from the community. At this point, so we ended up working with 2 communities in what we called our Family Listening Program pilot. We searched for an intervention in Indian country that we could see that was a family strengthening intervention that had cultural traditions to it, and we asked their permission to bring it to New Mexico. It was from the Northern Plains, to bring it to New Mexico from the Anishinaabe people and to transform it there. So we tried to take the evidence-based components of it and create a model that would bring in Jemez Pueblo traditions and Rema Navajo traditions and values and stories and keep the evidence-based family dynamic, family strengthening dynamic. So we contextualized it. It took a year or 2 to revamp the curriculum. We didn't just pull it off the shelf. We then were approached by an Apache tribe who had heard about us and said, could you bring this curriculum and program to us as well? So we had 3 pilots, different NIH grants, which enabled us, with pilot data, enabled us to create a shared tribal data implementation R01 that would test the effectiveness of this intervention. And they agreed to aggregate data across tribes. So it was this was building on many years of collaboration and togetherness for this to happen. So the intervention, I have a lot I could say here, but just briefly, it's a 12-session dinner-based intervention. It includes tribal history, tribal way of life, tribal vision, community challenges. All of this 8 through 11 is more the evidence-based family strengthening, anger management, communication stuff. All the beginning is completely based in their own community. They start with dinner, greetings, clans. Kids learn greetings, clans, Indian names. They share their home practice. They do separate activities in youth and adult groups, and they bring it together. They share. It's 2 hours with 4th and 5th graders. So we're testing the effectiveness of this intervention on 4th and 5th graders as pre-test, post-test, and their parents. The elders we do not do the pre- and post-test with. They are invited, and they're very important for the family transmission. And we're in the 2nd year of testing the effectiveness of gathering the data here. So I don't have that data. I do want to say that we also are a great believer in logic models to help guide what you're looking at, what you're measuring, how do you see change. So we have looked at risk factors from multiple levels. We have seen and tried to craft an intervention that addresses these risk factors. We have what we call an empowerment focus. This is called a community action project. So all the families choose a give back to the community. It's not just for themselves. They engage in a community action project and make a commitment to that. We want to see psychosocial outcomes all the way across, and we then link these to health outcomes and family. And we're seeing beyond, we're seeing the capacity of going beyond the child, beyond the parent, into the community in major ways. So we have started with a logic model and our own theory of change. We've used this intervention science idea and that implementation matters, that context matters, that cultural centeredness matters. And there's this wonderful interventionist, Penelope Ha from New Zealand, who talks about form and function of interventions. I'm just going to say it because I think it's really critical. The function of the intervention can be your evidence base. Like there's a function of family strengthening, but the form it takes needs to be contextualized. It's a very big difference in intervention science to say your dose and fidelity has to be actually absolutely the same written in a handbook and moved from community to community. So I think there needs to be, and there's a lot of us in this intervention world that are trying to say that let's look at this form versus function and really try and consider what we say when we're using the term evidence. We're looking at multi-level impacts and triangulation of quantitative, qualitative. We have pre-post tests, we have child journals, we have facilitator logs. We have what we call our 360 questions in this program, where the kids and parents at the end of the program say, how did I change? The parents say, how did I change? And then they all say, how has our family changed? So we're looking at this kind of qualitatively. And beyond the grant, we've seen tremendous capacities in research. We have our community, we used to call our tribal teams community advisory boards. They are now our colleagues, our tribal research teams. So they have a TRT, we call them all TRTs, they're our colleague tribal research teams, and they say to us, we can now watch another person coming in and wants to do research with us, and we'll say, are you a CBPR group, and do you know, and we don't want that research done in this community. So they've developed capacities in research and intervention. They've developed sustainability into their program. We're talking about it now in terms of the second year. How can we build it into the regular school curriculum and long-term impact, we hope. And this is from the pilots, not the current R01. So the pilots, we've had changes in anxiety, depression, pride and cultural language, ownership of program. They've already started adapting this curriculum, brought it into some classes. They incorporated into culture days in the summer youth program. Our facilitators are not us at the university, it's all tribal members. In one of the tribes, it's all done in their own language. Other tribe, it's more bilingually. And their family action projects. And they are now talking about what would it mean to bring programs together to create a prevention curriculum in our communities. So it's kind of, we're moving slowly together to try to institutionalize. I'll take back that word. Sorry, I never said it. Institutions are negative, bad research institutions. We can go there. We usually talk about, I don't know why I said that, the need to develop sustainability in communities as an outcome. So I want to say, I'm going to talk about two other examples. This is the Healthy Native Family Fellowship. It's been a 10-year leadership training program throughout Indian country. 2 to 3 people get together in teams. They have a leadership training 3 times a year run by folks out of Navajo Nation. And they've had 300 partners so far, 300 fellows, 125 teams across all parts of the country. Again, a logic model from leadership. Fellow changes the capacity to organize, to be an activist, as Doran said, worked within teams, not alone, worked with their local coalitions, and then community changes across Indian country from an individual level through policy level. One example in the Hopi tribe, there's 2 communities, 2 fellowship teams. One team has been looking at traditional dry farming and just building a healthy cooking approach, but then they got involved in an anti-GMO advocacy group. The other team has been working on more traditional learnings and pairing that with learning nonprofit management, because they want to build nonprofit organizations within the community as well for healthy kids. And together, now they're coming to a policy arena. So it's been a number of years building up from individual transformation change as leaders to then moving to work with their home coalitions on more local issues. Now they're organizing, as you can see, with a collaboration with the Food Cooperative, with the Cultural Preservation Office, with 25 religious leaders in the tribe, and a larger group of 9 tribes to keep that district of Arizona GMO free because of their heirloom corn seed. That is not just a traditional food component, but it's also a spiritual foundation. So you can see with this Healthy Native there's so many just examples of what these Healthy Native teams are doing. And we at the university have been the collaborative participatory evaluation group to support building their academic. We just have an article published in an international indigenous policy journal, and they're wanting to get that kind of knowledge out. So I want to talk about now, moving to the last part here, of the science of CBPR. I really believe there has to be better understanding of how partnering practices influence change, bring the evidence together with both sides, multi-stakeholders together to bring then a large range of outcomes. We've had 3 different sources of funding over time to build the conceptual model, to then validate the model. We're now on stage 3. I just got funded this last year from the National Institute of Nursing Research for another 5-year R01 to really promote this idea of how do we understand what is effective partnering? What's the added value of partnering? Why can't academics just do it themselves? Just change equity ourselves, or why can't organizers just change equity themselves? How do we need each other? Doran talked about commissioning data reports. We need each other. So this is the model. It looks complicated, that's why I gave it to you. But it really says 4 simple things. All research takes place in a context. It can be historic, mistrust, trust, whatever health issue. What's the policy, political dimensions in terms of funding structures or whatever. If you're partnering, you have relationships with each other of trust, of dialogue, of leadership, of sharing power. Do you have memorandums of agreement? What structures do you have together? If you're partnering, then research changes. If you're not partnering, you're an academic. You just set the research design and you're done. If you're partnering, you're going to get pushback. They're going to say, we can't do that kind of key informant group. We can't work with that Likert scale in our tribe or in our community. It doesn't work that way. We need to have community engagement throughout, and that changes the design. It also changes the analysis. It changes the interpretation. And if you're partnering then this has changed, then your outcomes are much beyond the grant or much beyond the specific research project. So phase 1, we created the model, which you just saw. Phase 2, we were able to do a study of internet surveys of about 300 partnerships across the country, We did 7 case studies. We had funding from Native American Research Centers for Health. So this one has ended, and we're writing this up multiple ways. I just want to say a few more things. We've developed measures, and we're trying to retest them now and refine them for what does it mean to be effective in your formal agreements? What does it mean to be effective in how aligned are you? Because a hypothesis is if you're coming from all different kinds of stakeholders, academics know one thing, community partners know other things. You're working with healthcare providers, they can be community partners as well, departments of health. How aligned are you, and as you move forward, and how many years does it take to become aligned? You talked about alignment a little bit, Doran. We also talk importance of bridging social capital. That means I, as a white outsider academic, I'm a perfectly lovely human being, but I alone cannot go into tribal communities and be effective. So I have in my team, in our team, the Center for Participatory Research, Native scholars, Native scientists, a mixed team of, multi-gender, ethnic, racial as well. And we have to change the face of academia if we're going to really be able to do this work. Interventions are culturally centered. I think I made a good point on that when I talked about the family listing program. You cannot just bring, even from an Anishinaabe curriculum, it had to change in Navajo, Pueblo, and Apache communities. But it's not just changed by kind of the images that you use. It's also the voice and agency of the people in making the change. If I just think, oh, I'll pick this from the website of Raymond Navajo, they have a nice image, we'll put that image on, we'll slap it on our curriculum. That's not what we're talking about. Partnership synergy from Lasker Weiss's scale we've used, and this partnership, how much do community members participate in the research process? Not just in deciding the question, not just in collecting data, that's when they do it all the time. We hire interviewers, we hire surveyors, but in the data analysis and interpretation and dissemination and the impact of the findings back in the community. And then what kind of outcomes? We're talking outcomes of sustainability, so we have metrics for all of these. How do you measure change at the community level? Of course, we're interested in the specific health outcome that equity grant or research project is aimed at, but we're also looking at systems and policies and changes in communities. Do the agencies get stronger capacities in working personally, can you identify that people themselves, by being members of the tribal research team, they're going back to school, they're getting job changes, they're being thought of as resources in their community. So we're in the middle of publishing this outcomes paper, but these are a number of our partnering practices that we have found have been associated with a range of outcomes, whether it's sustainability or changed power relations or improved agency capacity. So we're trying to kind of begin to understand what is it, how you work together matters, the value base, how does leadership happen, is the community involved in all stages, is there appropriate use of financial written agreement, are written agreements helpful, bridging social capital I mentioned, cultural centeredness I mentioned. We now have empirical data, it's cross-sectional data of 300 partnerships of partnering practices and outcomes. One case study I'm going to mention, it happens to be a faith-based case study from the Bronx. We did 7 case studies all over the country by different health outcomes, by different populations, by different rural, urban. In the Bronx, they started in 1999 with 7 churches, and they've now expanded to 70 churches as well as other CBOs. And the goal was to reduce diabetes and improve nutritional outcomes in the South Bronx, one of the poorest congressional districts in the country. And they got funded by CDC initially, then by NIMHD, National Institute of Minority Health Disparities, for wellness programs and system-wide changes. So the multiple ways I think that Doran referred to is also happening here in terms of integrating health messages into the liturgy, changing the church lunches, creating from the ground up their Fun, Fit, and Fabulous curriculum. But then they went bigger. And they succeeded against the dairy industry lobby in replacing whole milk food. They were going to do it first just in the Bronx. They were forced to do it through all of New York City schools. So they replaced whole milk with low-fat milk, and they were challenged that the kids would throw their milk away. They wouldn't drink it. They didn't like it. But they got that in the schools. And they started then to say, well, it's not just diabetes curriculum that matters, it's access to care. And so they did secret shopper surveys and started calling this medical apartheid, that there's one set of services for people living in poor census tracts in the Bronx, and then the Manhattan-rich census tracts get other access to specialty care, and we need to change this. So we helped them think, we learned a lot from them, and then we brought in this tool of a historical timeline, and we asked them, what does it mean? What do we need to know about your community? I know it's fuzzy, I'm sorry. What do you need to know about your community to understand this CBPR partnership? And they said, not when we got funded in 1999. We need to start with the burning of the Bronx. We need to start with the arsons in the Bronx. We need to start with the pastors who came in fresh from civil rights struggles. And they're our core. They're our core. And so then they pulled together the partnership, and we did this with all of our, and they talked about going for advocacy, bringing 500 people from the parishes up to Albany to demand that there be appropriate access to care for people in the Bronx. 500 parishioners at a time going up to Albany was, so they've been on CNN, this is kind of, I think, an amazingly effective case study. And there's a number of citations here as well in terms of, kind of seeing the multi-level, the lesson is kind of multi-level change with committed visionary people. We've been trying to understand what it means to create CBPR with the social justice agenda, and that the different ways that people can get improved justice. They can sit at the table with the governor, as Doran was saying, in terms of the governor listening to 1,700 people. There can be increased access to resources in terms of access to services in the Bronx. People identify with, whatever ethnic, racial, LGBT communities, that this is a way of organizing, and this happens with a lot of CBPR research. And then how do you ultimately have system change? And all of these levels of equity are important and can be supported by research. Just one example from San Francisco, they received NIEHS funding to study health and safety conditions of restaurant workers in Chinatown. So that, there's slips, falls, burns. They had to interview people outside restaurants because of people being afraid of losing their jobs. So they interviewed 400 people, the number one issue that emerged was wage theft. So they organized a big campaign around wage theft with evidence-based data from the restaurant workers, and through a receptive board of supervisors passed the first municipal ordinance in the country against wage theft. This is from a research project that this kind of policy work can happen. So when you're talking equity and big, this is again this link between, I would say the biggest link for CBPR in my world is the link between how evidence is used, constructed, and drawn from, and how public participation and organizing can be brought to bear. And university folks and community folks have different roles, but together they can create equity. So just to end here, we are on this next grant, and we will be we're refining all our instruments. We're going to be, again, surveying probably 400 partnerships this time and conducting trainings with partnerships to help them become more effective using self-evaluation tools, how they can become more effective in their own work. So that's my years ahead. Just kind of to end here, I just want to ask you what you're thinking of when you're thinking of evidence and thinking of outcomes and thinking of equity. And yes, you can evaluate the grant outcomes or evaluate the research project or evaluate the specific intervention, but it's much more than that, I think, when we're talking equity. It's really evaluating, like I'm trying to do, the partnership. Can partners be more effective? And then it's really looking at the entire bigger capacity of community benefit, community transformations, practices, systems, policies that we've been talking about. I also think it's self-evaluation of academics and universities and research institutions. How are we doing? Are we able to even reflect and acknowledge and honor the evidence that comes from local communities and the interventions that come from local communities and the ideas of what they care about coming from local communities? Because these four, I think, have to be together to really think about a change in health status and health equity outcomes. So, I mean, there's a lot of summary of NIH, why they're interested in CBPR, increased research trust, enhancing reliability of measures. There's a summary of community benefit reasons to engage in this kind of collaborative partnership. I don't think that policy change happens just from the top down. I think it happens from organizing and advocacy and mechanisms that include, so the CBPR effort is one strategy in this process. And just to end with one of my favorite quotes, she's a colleague and a friend. This is what I really believe, past all the science. Deep learning involves the whole body, blood and bone, not just a theoretical or cataloging of insightful facts and analyses. Deep learning moves the feet to walk in a new way, moves the eyes to see from the new perspective won by that walking, and moves the hands to fashion the tangible world into a new image envisioned by the new seeing. I mean, communities, if they are intensely engaged, will care enough about to want to transform and whatever we can do as academics, as partners to help them, whatever PICO or organizations can do that have more of a bigger vision and collaborative networks can do. But again, just kind of going back to having faith in people, this is the kind of work that I hope we can all do in terms of health equity. Thank you.
So maybe